welcome everyone today. We always like to start out at the top of the hour. We have another meeting packed with information for you today. This is the Superior Health Quality Alliance Regional COVID-19 all sharing call. And Superior Health Quality Alliance was formed in 2018. As you can see here, it includes the states on this map of Minnesota, Wisconsin, Michigan, North and South Dakota, and Illinois. The organizations are the hospital associations in Michigan, Minnesota, Wisconsin, along with Midwest Kidney Network. We have Stratus in Minnesota as a quality improvement organization, as well as MPRO in Michigan, and Metastar in Wisconsin. We are all part of the quality improvement organizations that support Superior Health Quality Alliance in our work. So our goal is to collaboratively improve the quality of health and healthcare for consumers, patients, clinicians, organizations, and the communities we serve. And through our COVID-19 calls, we wanted to provide information across the continuum of care for all of our providers that we help support in quality improvement. So we do want to keep this as an open forum as much as possible. We have started to have topics of the day. Today's topic is focused on home health organizations and how they've addressed working with COVID-19 in their environments. So we will have 3 home care agencies in the state of Michigan that have addressed this issue. They have wonderful materials as well that we will have available for you after this talk. And then we will open it up for questions. And if we have time, we also have sort of a case scenario that we wanted them to work through as well for you. We also are going to have the breakout sessions, if time allows, at 10:30, where we will go into state-specific rooms to chat about concerns regarding COVID-19 in your state, specifically Wisconsin, Minnesota, or Michigan. And please, just some housekeeping things to remember. Always mute yourself when you're not speaking, and remember to unmute when you are asking a question. You can always ask a question in the chat box as well. If you're listening through your phone, you need to press *6 to unmute. Always remember, don't disclose any personal health information of a patient that you're providing care for. And if you're having trouble with Zoom, you can just chat to Elena in the chat box and she'll help you out. And we are always open to your input as to what you would like as a topic for this call. We are continuing these calls through the month of June. We've secured that and maybe move forward if there's still continued interest. Next week on June 4th, we will be having an area agency on aging from Minnesota present on how they've addressed COVID-19, as well as some resources that they've developed targeted at community partners. So hopefully you'll find that of interest as well. All right, so with all of that, I would like to introduce, let's see, and just quickly, I'm not seeing her. Is Sara Blackstock on the line? There you are, Sara. Good morning. Okay.
Hi, I'm working on it.
Hi.
Internet's a little bit sketchy today.
Great. I'm glad you're here. We have 3 home health agencies on the line today that are going to provide us their perspective. Sara Blackstock is the Administrator and Director of Business Services and owner of ABF Home Services in Michigan. Donna Filer is the Regional Sales Director of Alara Caring, and that I know covers quite a few states outside of Michigan, but I work with her mainly in Michigan. And Salim Binderwala is the CEO of Tone Home Health Services in Michigan as well. And so I think what we'll do is just have Sara go first and talk about her perspective and how her agency has addressed COVID-19. Then, just a brief introduction, and then she'll then lead into Donna and then Salim. and then we'll open it up for questions. So Sara, if you'd like to talk about some of the things that you've been doing at your organization.
Hi. At ABF, we started, obviously, when everyone else did with the we started the stay at home with a survey from CHAP. They were there the day that everything was shut down, so that was quite interesting. We started with field staff orientation and gathering of the PPE, which everybody knows is hard to get the PPE. Working with the Region 2 North Committee and some other private sellers, we were able to obtain enough PPE for our staff, and then the education as we received it was given right out to the staff members. We had not a COVID team per se, but we instructed them all on infection control and the probability of catching it in the field. We had 2 nurses that said that they had no problem with staffing the COVID-19 patients, so they were our primary go-to nurses, and then we had a couple therapists as well. Again, we did a really intense in-office training on donning and doffing of the PPE so that the staff members were confident and comfortable when they went out to the patient's home. From there, we also educated the patients. We let them know that the staff would be coming in full PPE. So they would have a face shield, a mask, goggles, gown, gloves, booties if they had them, and to make sure that there was an area where the patient was isolated from the rest of the house. So if it was a bedroom or if it was a living room, we would like to take care of them in that area without anyone else around who was not infected. If there was a family member that had to be involved in the care, we made sure that they were masked as well. And anyone that had to be within 6 foot of the patient, if it was active, we asked them to mask and gown if they were assisting with care. And glove, I'm sorry. We also instructed the families on when the staff came out, they had to have a place where they could take off their PPE and leave it in the home. So we asked them to put up a table, a garbage can, and an area where they could discard and leave it there, either on the front porch or near the front door, so that they didn't take it to their car with them. And then it's just been ongoing training and PPE acquisition, I guess it would be, this whole time. And I think the family members have been pretty receptive. I know we have the scenario that we're going to talk about in a little bit, but the family members have been pretty receptive and interested in the training. And of course, in our starter care packs as well, we do a lot of education and we have a lot of handouts that we give to the patients about signs and symptoms and how the family can care for these patients without the risk of infection. And once we had an overstock of just the regular face mask before everyone were making the homemade face masks, we were giving the patients and the patients' caregivers a few so that they had them during service.
I think that's very nice. Donna, would you like to say some of the things that Alara has been doing?
Sure, that sounds great. Alara Caring, also known as Great Lakes Caring, for about 25 years here in the Michigan area. We changed our name in 2019 to Alara Caring. We joined another enterprise and created Alara Caring in 2018. So we cover 16 different states. So the great thing about this is our company was very well positioned to address the immediate needs of this crisis when it occurred. On March 13th, when the president came out with the national emergency, our CEO followed up with this letter that Elena has there on the screen for you, basically letting our referral sources, our partners, and our community know, and our patients know that we're going to be a partner for them during this crisis, and that we are prepared to be able to deliver care for them in a safe environment, right care, right time, and right place. So Elena, do you want to give the second slide? Our clinical team and our management team worked over the weekend once that announcement was made to create a flow chart. And we also put in place that our staff would every day call in and really report their temperature and any symptoms that they had. This is a flow chart that we use both for our staff and also for the patients and anybody in the home care, providing care for their patients. And if you look at the flow chart, it really addresses anybody who has symptoms and what we want them and need them to do if they express any symptoms or have any kind of conditions where they might have COVID-19, and what we would do at that point. So it's a very detailed process. Obviously, self-isolation was brought in, and self-quarantine is brought in if someone does have any symptoms. But you can see from the flow chart here that our staff and our patients and any caregivers in the home will be really doing this flow chart or self-check when we go into the home, so we can be assured that everyone's following the same process. The second thing that we did as a team is we went ahead and created the next slide, Elaine, if you could show that real quick. There were changes in the COVID environment once this occurred. So suddenly patients that were maybe not normally homebound were suddenly homebound because they were at risk for attracting the COVID virus, or were at risk for it. We're able to now qualify for home care. So we wanted to let our referral sources know and our patients know that someone who maybe traditionally wasn't homebound may now qualify for homebound status for really home health. The second thing we want to do is look at the level of who could certify care. Nurse practitioners for Michigan were suddenly allowed to write home care orders, which they weren't normally allowed to do in the past. So we wanted to let the physicians know who are doing their virtual visits out there that now your nurse practitioners who are helping you can also really send in a home health care order. In the past, it would have to come from the physician. So it was an ease for them to know that too. And the last thing we did was telehealth. We've always done telehealth in the Great Lakes environment. We've done it for our high-risk patients and helped monitor their COPD or the CHF conditions with a telehealth cardiac monitor. We also then released a new method of televisits or virtual visits into the home. So that was something else we wanted to let them know about. Many patients during this time expressed a lot of concern with having someone in their home. So Elena, to the next slide. The second thing we did was we really addressed with our patients and our physicians, is home-based care safe right now? And we kind of wanted to bring into the forefront what Sara was talking about, what we did with our PPE, making sure that our staff was fit tested for their visits in the home, and making sure that they understood that we had a really detailed process for them, and that the patient could be assured that we were going to be very safe in their home, and we're going to keep our clinicians, their patients, and any of the caregivers in the home safe when we entered the home to care for that patient. So this was a nice piece to bring out into the community for both the patients and the physicians to know that we as a company were prepared to make sure that everybody was safe in the home during the COVID crisis. The next thing we did, next slide, Elena, is we talked a little bit about the telehealth. So as things were changing with the COVID environment, we were actively working on virtual visits. We knew that our physicians were doing that in the home. And then even though they really hadn't discussed from a CMS perspective how we were going to be reimbursed for that, we did still launch our virtual visits. So the idea there was that we could provide physical visits and virtual visits for those patients who were concerned about someone in their home. It would then provide more care for them in a safe environment, and really help those patients that really needed someone in their home but were very fearful of having a physical person in their home. We could then supplement those with virtual visits. Those are FaceTime visits that were done through a platform called HRS, and it was done in the home for those patients. We did have to pre-screen our patients to make sure that they were going to be able to operate the device. It had to be done on a tablet or a smartphone, and the patient obviously had to be of a cognitive ability to be able to master the virtual visit or have someone assist them for that. So we did go ahead and launch that into our offerings for our patients. If we did have someone fearful of us coming into their home during the COVID crisis, again, trying to address the patient's needs at home so they didn't have to go to the hospital. And then the last thing we did, which was really, again, for the community, could be for the hospital staff, could be for anybody. It's really coping in stressful times. We really wanted to address this because we knew that there was a lot of stress out there for our patients, our clinicians, our community partners, and our referral sources out there of being around COVID crisis and how they were dealing with it mentally. And we really wanted people to know that if they were stressed, that there was someone to talk to, and that they really should get home health involved if they wanted to create a connection and not, really have an episode where they had to go to the ER. So it was just, again, a opportunity to really recognize that we were all going through this together. It was definitely a team effort and a partnership, and that together we could get through the COVID crisis. So those are just some of the tools we used. As Sara kind of indicated, PPE was a concern for all of us in the beginning, but I think a few of the key companies addressed that very quickly. We were fortunate to be one of those key companies. We were able to fit test our team as quickly as possible. Sara and I worked with one of our large hospital systems. I know they were instrumental in providing extra PPE for us when we were all looking for it, meaning masks and items like that. That collaboration as a community was key for us in the beginning. I was very appreciative of that because I think during these crises, we all have to work together on that. So that was important for us to do that also. And now we're just continuing to really monitor our patients. We have a number of COVID patients we're treating in the home still, quite a few that are pending. The testing has become more available, which has been very important for us as a community. But we are just continuing to try to work with our COVID patients and work as a community to try to help out during this COVID crisis.
Thank you, Donna.
Yeah, no problem.
And Salim.
Hi, good morning, everyone. My name is Salim Binderwala, and I am a physical therapist and administrator at Tone Home Health Services. We serve the Tri-County area in and around Detroit. Our current census is about 375 patients, out of which currently we have 62 COVID positive patients that we are taking care of. On CMS Home Health Competitor, we are a 4.5-star company for patient outcomes and a 4-star for patient satisfaction. Our current rehospitalization rate is about 15%, which is less than the Michigan and the national average. Quite a bit of information has already been provided by Ms. Sara and Donna, so I'll try to not repeat myself. Since March, things have completely changed around the world, and home health was no different. It was a fact that mortality rate for COVID was highest in the senior population, and hospitals was one area where where nobody wanted to go because there's a high level of COVID patients over there. So our job as a home health agency to prevent seniors from ending up in the hospital became more important than ever than any other time in history. Home health was already feeling its challenges. Suddenly all our staff was made to work from home. Patients were declining visits from our staff because they were worried that the staff might bring COVID to us. Initially, some of our field staff were refusing to go out in the field. If that was not enough, home health agencies were also dealing with the PPE shortage that was quite evident. Companies who did not take any extraordinary steps during these times already must have felt the side effects of this pandemic. At Tone, we started acquiring PPE from irregular sources. McKesson and our regular suppliers were busy supplying to the hospitals in other areas. So we had to go to other sources online and different websites like Grainger.com, Uline, and eBay and try to get gowns and masks stitched in the community to provide to our staff. We invested time to re-educate our staff on the on and off of the PPE and had to create a well-defined process for dealing with our COVID positive patients. We made a special task force to take care of that. CHAP had a very good, well-defined process for seeing COVID positive patients, just in case if anyone wanted to reach out there. So we made at one point, it was very difficult to distinguish whether we are going to a COVID positive or not. So we made a policy in our company that every patient, every clinician, every visit will put full PPE from top to bottom, irrespective if the patient was COVID positive or not. Can we go to the next one? Sorry about that. I missed out. Since hospitals and nursing homes and doctors' offices were not allowing any community liaisons, we use them to become wound care supply distributors, and PPE distributors for our field staff. Our job was to prevent hospitalization, and key to it was early detection, followed by effective intervention, and powered by seamless real-time communication. If you can click the next slide. One more, please. And this was made possible by an app that Tone Home Health has been working on for the past 2 years. We are calling it Home Health Notify. Ms. Elena, can you click one more time for me? It was a simple HIPAA-compliant communication app with built-in home health processes that helped our agency become leaner and more efficient. What we did, if the next one again, it improved the care collaboration between the team. It made all the processes quite transparent and improved our outcomes as an agency. Here I put some of the slides of how we used it during the COVID times. So we could just filter all our COVID patients. On the first slide on the left, if you can see, if we just by searching for COVID, we could put all our staff, all our patients that were COVID positive in one slide. So the team in the field could see which patients were, when they were entering the patient's home, whether they were COVID positive or not. We also made a special COVID task force, the second slide, where we shared with our complete team in the field all the best practices that were shared by CDC and WHO. The third slide, what made this app different from others was that apart from all the field staff on the group, we also had the physician and the patient part of that group. So in the third slide, you can see how the physician is communicating with our field staff in real time. Obviously, we could share all the videos and pics and lab reports with everyone in the field with the staff. The bottom line, last slide, please. The bottom line for the COVID was to what we did was creating a special COVID task force, specifically for all COVID positive patients, complete PPE for all staff at every visit, irrespective of patient diagnosed with COVID or not, timely education, training of patient and caregiver and staff, sharing best practices to eliminate the fear of the unknown, generous and lavish, abundant praise and words and reimbursements of all field staff. They were really the superheroes for putting their lives and that of their families at risk. Effective care delivery processes powered by real-time communication, resulting in preventing hospitalizations and improving outcomes for those patients. Thank you for the time.
Thank you so much. Thank you to all three of you. Some things were standardized and some things were very specific to the specific home care agency. At this time, I know people were asking about if the materials would be made available afterwards, and I believe all three home care, if you have anything that you want to share, are you willing to share it with the group afterwards? Materials you have and such?
Yes, for sure. I didn't put any slides in there, but we have kind of similar to what Donna had for the screening, and our intake does a screening every patient that we get, and then the staff are supposed to do a screening every visit, and it's built into our EMR. And then we have a couple, not a flow chart the same as Donna's, but other handouts and stuff that I'll send to you, and then you can send it out.
Thank you.
You know, and the one other thing I just mentioned too, Barbara, is that when the clinicians are doing these visits, I think a lot of us are putting, priority with trying to keep the clinicians from transferring any infection to anybody else. So our clinicians are trying to move those visits to the end of the day if they can. So that's the end of their day visits. So that's another piece in there. I think both Sarah and I have talked about before too, that you're trying to time those visits out so that if they are going to see patients that are COVID and non-COVID that day, that they make sure they separate those patients as much as they can so that there's no cross-contamination issues. So
great. Thank you. Good tip. Yeah, I'm not seeing anything in the chat right now, but I actually had a question. It was something that Sara brought up. You said that you had some information in the starter kit for the patients that you see, just about how family members could care for a COVID patient. I was wondering if you wouldn't mind giving just one or two of those tips. I know family members are always so concerned, and they do want to provide care, and many times they are the ones that are providing quite a bit of care. So did you have any like high-level tips or things that that sort of provided them some comfort when you made those suggestions? Sarah.
My internet just froze, so I'm not sure the full end of that question, but I get the gist of it. We actually kept it very layman's terms so that they wouldn't get nervous. Like Donna said, you want the family to be comfortable and confident and to allow the staff in. So comprehend. So they're basic like hand washing, and like a little picture of them hand washing and when to mask, when not to mask, and a picture with the fever or no fever and how to read the thermometer. And just to make sure like step by step, and it's very an animated type flyer. Because we deal with a clientele that are middle of the road with comprehension and education. So we want to make sure that everybody is comfortable in the material that we give them.
Great.
And like I said, I'll attach them and email them out to you or Elena, and then you send them out with the rest.
Thank you very much. Thanks. I appreciate that. All right. Elena,
we did get a question in the chat asking who trained your staff to use PPE?
We're a large organization, so we have an entire infection control team, but I would think even if you're a small organization, you probably have one or two people that are designated as infection control group. So we basically had those people kind of take the lead and really, and that was a lead per branch, and they went out there when they fit tested the staff. They had to be fit tested before they were to ever see a COVID patient, and I think going forward, they were fit tested regardless then if it's COVID or not COVID. But in the very beginning, we made sure that everybody understood you could not see a patient unless you were fit tested and had the proper PPE. And our staff is, I think, pretty comfortable with that. We've dealt with infection issues before we've had been fit tested, but I think it was just the magnitude of the amount of staff that had to be fit tested was a challenge for all of us at that time. So I think we all rolled it out. For us on our caring, we had a definite team that were at a higher level, and then they were transmitted down to the branch level.
To add to that, what Ms. Donna said, it is not common in home health to be wearing PPE, and it's not a common practice. So it was a challenge, and there are for smaller agencies. There are a lot of YouTube videos on donning and proper donning and doffing methods that is very well demonstrated, which we could always share with our clinicians once we go through it ourselves. And because it was very challenging to bring this, there were no meetings occurring in the office. So that was another challenge. We are not calling people in because of social distancing and all. So it was more of sharing online resources with them rather than trying to get them in the office and trying to train them.
Actually, we had a nice session of our clinicians videotaping their way of donning and doffing off. Oh. Yes, and it was really interesting. And it was collaboration, so everybody could watch. A lot of criticism, constructive, but it worked well. It just brought a lot of confidence and collaboration, like a good team spirit.
In the very beginning, we did have in-office training. We had the clinical director. We actually did a PPE drop. So we had bags for all of our staff, and we met them in certain locations and did, we drop it on the ground, they come and pick it up, that kind of stuff in a bag. But in the very beginning, the two main staff members that we have, or anyone who was not comfortable, we have a very large conference area and the back half of our office. So we had the clinical director with one person in the back and making sure that they did it correctly to get it off and put it in the bag and whatnot and tie it without any infection. And as Donna said, they're all trained in infection control. We just made sure that they read the policy again and were reminded of the importance of the cleaning and the hand washing and the hand sanitizer, and made sure that everyone had an abundance of that.
There are a couple other questions in the chat now. And I think, Donna, you kind of touched on this a bit, but how were the home visits arranged with COVID positive patients? I don't know if anyone else wants to add to that.
At ABF, we did the same thing. We told the staff to make sure it was their last visit of the day or last visits of the day, or if their schedule worked, that they could do like their COVIDs on Monday, Wednesday, Friday, or whatever the visit was. And as Donna said, we did some of the phone or video FaceTime visits with these patients and family members when they were a little leery about patients getting in. So, but we always made sure that they saw them all on the same day, and or they were their last patients of the day, so they could go home and shower and not have to sleep in the garage.
And the other thing we did too, and I think Sara spoke about it too, we all pre-screened our patients before we went out and asked specific questions to find out who was going to be in the home, if anybody was having any symptoms in the home. So we knew what we were walking into, and really trying to prep the environment so that, you know, like Sara was saying, that we really were in a room that was isolated with just the patient if it was possible, in order to keep other family members away. So, you know, that was also something we did too, is pre-screening them the day of the visit too before we went out there.
And on the introductory phone calls to let the family know that we want the least amount of people in the room around the area, to arrange for a garbage can outside the house so that, like, you know, our staff can take off the PPE and like, you know, have designated areas, things like that was discussed with before our staff went out to the patient's house.
Thank you for that.
Sorry.
Oh, go ahead.
The screening was very extensive. We always would start it right after receiving the referral in the office, and then the clinicians would call. So there was a lot of pre-screening done prior to a visit. It develops a good rapport with the patient and the family. So there is a lot of knowledge of what's going to happen. And there is just like even the phone call and the comfort of talking about the issue would just allow the patients to open the door to those strange-looking clinicians wearing all PPE, like coveralls with the goggles and the shoe covers. So that was very extensive phone call from quite a few people involved to a case. And we were lucky because we had a good team that was committed just to COVID patients. Initially, we were thinking about maybe putting COVID patients to the last visit of the day. But there was a lot of issues with our clinicians. Again, they were so uncomfortable. They were calling back. They would say yes, and they would call back and say, I'm taking care of my elderly parents. Can you take me off? So we decided actually to create a team and have people that are going to be reliable.
And Justiana is from Tone as well, just so everyone knows. That's okay. Just wanted to let everyone know. So, and I think too, just to segue, I was going to ask a question about, Salim did bring up honestly that some of the staff had their own concerns about going to visit COVID positive patients. And I think Justiana kind of addressed that a bit on how Tone addressed that issue. Because I think that, you know, everyone, certainly initially and still ongoing, people are very concerned about it. So, and I think if you're honest with your staff, it works much better, and you try and work with them as much as possible instead of just alienating them. So. And
as administrators, it was very important for us to be non-judgmental of those clinicians too. Like, you know, we never know their background. They're taking care of sick parents at their homes, or like very elderly at home, or like, you know, newborns. So they and it was very important that we did not make them feel uncomfortable of saying, no, we are not going to go to COVID patients. So we were quite empathetic about that situation too.
We just have two more questions in the chat. So I'm going to ask them together. How do you forecast daily PPE needs? And did you have any visits from the state?
I can go first on this one, maybe. Sorry. So very early on in March, there were quite a couple of cases where like my staff would go say, because we knew that the patient is non-COVID positive. But after a week, we would get a message from the family that someone in the home was detected COVID positive. So we realized that, we cannot anymore distinguish between who is positive and negative. And that was becoming challenging as we were moving more and more into late March and April. So as a company, we just decided that all visits, everyone is going to be doing full PPE, irrespective of COVID positive or not, because that's the way it was. I mean, we literally would come out of the house and 2 weeks later or 1 week later, somebody is positive, either the patient himself or herself or the staff members. So we knew, what is our census in our company. So we had to just, get as many supplies as we could. And we got lucky in acquiring those quite early on. We got a few suppliers who would, again, not McKesson and our regular suppliers, but others other than that we were able to get enough PPE for entire staff throughout this whole episode. And we did not have any state visit, but I heard that many companies did. And it was not much of a regular survey with a 3-day survey like usually they come. It was just a few hours where they are touching base with infection control and emergency preparedness programs. That's what I had heard from most of the companies that had the survey. Sorry, Ms. Sara, go ahead.
For a LARC hearing, we basically would release, like I think like Salim was saying, you couldn't really tell if they were COVID or not COVID in the beginning. So we really tried to make sure that all of our staff had PPE that they needed. And those clinicians that were seeing patients that were confirmed positive with COVID were given extra PPE. So we had a bag of PPE that every week our clinicians would pick up from our local branches, or there would be a drop-off site, just to have what they needed to go into the homes. And then we would give those clinicians that were seeing additional COVID patients extra PPE when it was needed. So absolutely, like I said, I think they started out with like 10 masks if they needed it for just a normal clinician who was going to see quote unquote non-COVID patients. And then if they needed more, they were given more PPE.
Same, actually, Donna, you and I are pretty much on the same page. Every clinician was mailed out 10 masks in the beginning. So no matter who they were seeing, they had 10 masks. Then as it was becoming more community-wide, everybody was mailed more masks and goggles. Then as it was everywhere, all staff were on comfort level were to either wear mask and goggles or mask and face shield on all patients, no matter what. On COVID positive patients or COVID suspects patients, they had to wear full PPE, and we mailed them that and or met up with them wherever they were location-wise. We did modify the burn use sheet that was presented about a month and a half ago from one of the MPRO or the KeyPro programs. It was based more for hospital. So we found something similar and put the two together to tweak it to try and do a burn rate. And we do it more by staff member as opposed by agency or patient member. So if nurse A has 10 COVID patients, we know that they're going to go through, 3 times as much or 4 times as much PPE than nurse B. So we made sure that their stash, per se, was always fulfilled and either met with or mailed out weekly.
Sara, are you referencing the one from the University of Michigan presentation that we had?
Yes.
Okay. And that's still available for people if they're wondering the reference. So we can reference that again to make sure that people know what Sara was talking about.
It was very hospital-based. So we did take sections of it, like I think 1 page of the 3 pages, and then the clinical director found another one online, and we kind of merged those together. So you put in all of your stock, and then who's using what, and then it tells you the depletion rate by clinician as opposed to by patient.
And I see Elena put the link of the first resource you were talking about in the chat for people. Okay, thanks. Okay. All right.
I think that's all for questions that I see right now.
Okay. I see we're a little bit past the 10:30 mark, but let's see. All right. Well, we'll give one more minute here for last call for any other questions to our wonderful panel today. I know I have appreciated this. I really appreciate the three perspectives. And again, I feel like some crossed over and then some were very unique. So I really appreciate all of you being here today. And I think working in the community, it's, I think any setting, it's a very challenging time, but working in the community to help your staff as well as the patients that you care for feel as comfortable as possible and continue to provide that quality care that I know all of you do is a challenge. So I truly appreciate it. And I appreciate you all taking the time today. And Janelle Shear from Minnesota says, thank you, speaker, for a wonderful presentation. Thank you, Janelle, because I know your heart is in home care as well. So we have a special spot for that.